Good evening, everyone. It's about 5 o'clock. I want to thank you for joining me today. Thanks to everybody who posted questions, and of course, I'm happy to answer any questions that are live that come up on your mind while we're doing this. My name's Dr. Avital Harari. I do want to just stop and say that I hope everybody's safe and healthy during these times. This is a very difficult time right now. My thoughts and prayers are with everybody and their families, and hope you're staying safe and socially distancing. I'm going to start today. I can give it another minute or two. If you want to start posting some questions, that's great. I can see them on the left-hand side, but I also have some questions from previous posts that I will go over. But at the beginning of my talk, I really just wanted to go over a few basics about parathyroid disease and parathyroid syndromes. Not into too much detail, but a little bit that might give the setting for those of you who might be joining that don't even know what the parathyroids are and why we're even talking about them. I do want to say a special thank you to Angela Scherertz. She has been wonderful in helping me, and to the parathyroid support group for which we are supported by for today, this talk. So give me a second, and I'm going to bring up my screen, and I want to just share some slides with you and go over a little bit about parathyroid basics. Bear with me, it's my first time doing a Facebook Live event, so hopefully this is working. And I hope people are able to join right now. All right. I think that is working. Okay. So this is the slide for my event that you guys saw posted previously. It's everything you wanted to know about parathyroid disease, but we're too afraid to ask. So hopefully you'll come up with some questions while we're doing this, and hopefully this will stir your memory or your thoughts as to what you might want to ask. I'm Dr. Harari. I'm an associate professor of surgery at the UCLA Department of Surgery. I'm also an active member of the American Association of Endocrine Surgeons. Thanks again to the Parathyroid Disease Support and Awareness page. So just a few basics for you. This is some parathyroid anatomy. So most of us were born, this is something that I speak with to my patients on a regular basis when they come to me and speak to me about parathyroid disease. And I just kind of want to go through the basics because a lot of them have come with knowing that they have high calcium, but they've read a little bit on the internet, but I like to walk through with each and every one of them their individual cases. And a lot of times I'll go over something like this. So most of us are born with 4 small parathyroid glands, 2 superior glands and 2 inferior glands. But there are some of us that are born with 3, 5, 6, 7. But like 95% of us are born with 4, and they're located typically in the neck, but embryologically, they actually travel from the base of the tongue down to the mid-chest. And 2 of them usually develop with the thyroid and 2 of them with the thymus. So you can actually find them anywhere, which is why if you're going to a surgeon, going to somebody who's experienced and knows where to find these parathyroid glands is really important, because they almost never look exactly like this picture. As you can see, these pictures, they're usually located behind the thyroid. They're very small if they're normal, but even some abnormal glands can just be slightly enlarged. So I always tell my residents, every parathyroid for every patient is different from the other. So I usually try to figure out what is abnormal for that patient, and typically it can change from patient to patient. These parathyroid glands control the body's calcium levels, and they produce something called parathyroid hormone. So if you're a patient of mine, or you have been a patient of mine, you know this graph pretty well, the one on the right. I tend to draw it for every patient so they understand a little bit about the parathyroid normal functioning. It's like a thermostat. There's a feedback loop so that as one elevates, the other should be shut off, and that's usually the calcium level. So the parathyroids react to the calcium. So as the calcium lowers, it should stimulate your glands to produce hormone. And as the hormone goes up, it then stimulates your parathyroid glands it stimulates the absorption of calcium from these 3 organs. So the hormone usually acts on your bone, your kidneys and your intestines to help absorb calcium so that the calcium levels start to rise again. And as they rise, it should suppress the hormone. And so that's this feedback mechanism. But when you have problems with your parathyroid glands, this feedback mechanism just doesn't work anymore. And especially with primary hyperparathyroidism, suddenly you have 1, 2, maybe 4 abnormal glands that are just secreting hormone indiscriminately. It stops listening to your calcium levels. It just continuously secretes hormone. And that just then causes your calcium levels to rise and rise. And typically, the typical diagnosis of primary hyperparathyroidism would be when you have an elevated calcium and an elevated hormone level. Now, there are atypical presentations of primary hyperparathyroidism. Some have normal calcium with elevated hormone, and some have normal hormone with elevated calcium. But there are several other things that need to be ruled out to make sure that you actually do have primary hyperparathyroidism. For example, when you have a normal calcium level and an elevated hormone level, the most common cause of that is actually low vitamin D. Sometimes you can have renal insufficiency that causes that. Also, with high calcium levels and inappropriately normal hormone levels, most of the time that is primary hyperparathyroidism. But some of the time, hypercalcemia can be ruled out, of other causes need to be ruled out. Sometimes malignancy can cause that, sometimes multiple myeloma. So it's important to have somebody really work through it, because obviously you don't want to be put through a surgery or some sort of treatment when you might not need to. These are some causes of hyperparathyroidism, and we typically treat as endocrine surgeons all 3 of these. The primary cause, which we were talking about just a second ago, secondary hyperparathyroidism, and tertiary hyperparathyroidism. Primary hyperparathyroidism you can see in an adenoma, parathyroid hyperplasia, which is basically all 4 glands that are involved, parathyroid carcinoma, which is very rare. MEN1 and MEN2 are endocrine syndromes that can usually present with abnormal parathyroids, and all 4 of them are typically abnormal. Primary hyperparathyroidism can be associated with jaw tumor syndrome, which is usually a carcinoma in those cases, or has a high risk of parathyroid carcinoma. In secondary hyperparathyroidism, you can have it's usually due to renal failure or low vitamin D. And tertiary hyperparathyroidism typically is in a patient who's had secondary hyperparathyroidism for a long period of time, then receives a transplant and has persistent hyperparathyroidism after the transplant. Usually, those secondary patients are treated medically with Sensipar and should regress after transplanted, but if they don't, it becomes a tertiary problem, and sometimes we have to operate so that the hyperparathyroidism doesn't affect the renal transplant. So as a lot of you probably know, there are a lot of signs and symptoms of parathyroid disease, and a lot of these signs and symptoms overlap with many other things. But there is a syndrome with these symptoms. We usually called it in medical school bone stones, groans, psychic moans, and fatigue overtones, which include weakened bones or osteoporosis, osteopenia, kidney stones, this is a big problem, abdominal pain, joint and muscle pain, and then psychic moans and fatigue overtones can be mood disturbances, fatigue, delirium, depression, anxiety, memory loss. You can also present with a hypercalcemic crisis, especially those people with parathyroid carcinoma. Other symptoms that can be involved are increased thirst, urination, constipation, heartburn. Sometimes you can present with ulcers and itching. So who should we operate on? This is a statement from an international group, the 4th International Workshop, that was done in 2014. This group has met several times in the last 20 years, as you can see, or last 30 years. The most recent iteration of this is guidelines for how and who we are going to operate on who don't have symptoms. I mean, most of us will operate on people who have symptoms, but what if you don't have symptoms? So these recommendations have changed slightly over the years, and most recently these are the last column, and you can't really read this, but if you want you can look this guideline up. But it basically says that if you have a calcium level at least 1 milligram per deciliter above normal, a bone density score that's in the osteoporotic range, which is a T-score that's less than negative 2.5, a vertebral fracture by X-ray, CT, MRI, or those imaging modalities, creatinine clearance less than 60, a 24-hour urine calcium greater than 400 because you're more likely to form stones. If you have stones on an X-ray, an ultrasound, or a CAT scan, so you don't have to just present with a kidney stones clinically, even if you have it on an X-ray, you should be worked up for primary hyperparathyroidism. You know, I've told people that their primary care physician should work them up for this disease process for both osteoporosis and kidney stones, because it's possible that there's a treatable cause to those. So who else should have parathyroid surgery? As I mentioned, those with symptoms, those with osteoporosis. Sometimes we consider osteopenia, a history of kidney stones, life-threatening histories of hypercalcemia. Some people have actually pancreatitis due to their hypocalcemia, a rare bone deformity called osteoitis fibrosis cystica. Patients younger than 50, those people have a high likelihood of developing worsening or symptomatic disease. And we don't know how to predict who or when. So even if they're mild, if they're younger than 50, we usually will operate on them. Also, there have been studies to show that you have actually worsening survival in people who don't get this treated, and worsening heart disease and kidney disease. So most of us will offer a surgical, at least consultation, to almost everybody who has primary hyperparathyroidism, because many people will benefit from this. And the age of 50 is not a hard line that you should think about. Sometimes people who are 60 will have a higher risk of heart disease if they live to be 90. So it's not unreasonable to at least talk to a surgeon, even if you have mild disease. Importantly, though, you need to find an experienced surgeon. This will decrease your risk of complications during the surgery, and will decrease your rate of recurrence and persistence. And this is just one of the groups of surgeons that does this. I am a member of this organization, the AAES, and you can find a surgeon at anywhere throughout the country and throughout the U.S. On this website. But also there's the International Association of Endocrine Surgeons that have surgeons throughout the world that specialize in this and do this quite often. You should have a surgeon that's doing this very often, at least 50 a year, maybe more, so that they are really familiar with the anatomy and how to treat these. So what causes primary hyperparathyroidism? Usually it's either a single adenoma in most patients, but there are people that have multi-gland disease. That could be 2, that could be 4. Very rarely is it a parathyroid carcinoma. Those people usually present with significantly higher calcium levels. I have seen more and more multi-gland disease lately. I don't know if it's a shift, if it's something environmental, or if it's maybe just a referral, but a referral bias, because I get a lot of people with negative imaging, which tends to have a higher rate of multi-gland disease. But for the most part, we still sort of say that most people have one gland that's affected out of the 4. So how do we treat this? You can either treat it surgically or medically. Surgically, it's really the only cure. And usually most people who can have surgery and have an indication for surgery will undergo surgery. You do need to have an experienced endocrine surgeon. But sometimes medications can be given for this. Sensipar, bisphosphonates. Some of these are given to very, very high calcium levels, like on bridge to surgery. Maybe you have to wait a couple months, especially now during the pandemic. You might have had to wait, and maybe your calcium levels are 12, and your doctor put you on Sensipar. This is not a cure for your parathyroid disease, and there have been conflicting reports about how it would help you. It might help some symptoms, but it might not help your bone disease, for example. So usually we give Sensipar to patients who cannot undergo surgery, people who have really bad hearts, who are really sick. That can be treated other ways just to bring down their calcium levels. That can, in itself, the high calcium can affect your heart and the way that your nerves and your muscles react. So that's one thing that this medication does. Typically, and if you have mild disease and are elderly, let's say you're 85 and your calcium is 11, you might not do anything. You might just follow that. So it's very nuanced based on the person and how they present. So once you're diagnosed, you do go through localization studies. I want to emphasize that these localization studies are not for, if they're negative, it doesn't mean you don't have the disease. The disease is, we diagnose the disease based on your blood work and sometimes your urine. It is not based on the localization studies. These are specifically for us surgeons to use during surgery. It helps localize for us. It's a little bit of a roadmap, but if it's negative, we still know how to go find them. These tests help identify hyperactive glands, but sometimes they just anatomically show us where a gland might be. And they might help focus our exploration. A lot of these, and I'll tell you the 2 different types of explorations, are based on the localization studies. Minimally invasive parathyroidectomy is just basically a small incision, a very small incision right here. And you can do a bilateral neck exploration and a unilateral neck exploration through the same incision. So your incision doesn't really need to be much bigger. What are the imaging modalities that we have to look for parathyroid disease? We are very lucky now. We have many imaging modalities and much more than even when I trained as a resident. So initially we only had sestamibi, and they were just this planar images that was very grainy. You've probably seen some of them, and they're very difficult to read and almost always negative. Then they came out with the SPECT-CT, which is basically that grainy image, the nuclear medicine image, fused with a CAT scan. And that really helped because it gave a three-dimensional view to the things that lit up on the nuclear medicine scan. Sometimes you get just the SPECT, which is basically a 3D nuclear medicine image, which is grainy in 3 dimensions. So I typically would prefer a CAT scan with that. Then we had the ultrasound. The ultrasound is user dependent, but it also you might not see everything on the you might not see the parathyroids. They may be hiding way posterior in the neck, and you might not see that. But the ultrasound is super important because you may have thyroid pathology. So if you have a thyroid cancer, for example, we need to know that as surgeons before we go in, so that we know that we can treat both things at the same time. The CT scan then came out, the 4D CT scan. This was around 2006, 2007. This is a great scan. It gives a lot of detail, and even very small parathyroids can be found on the scan. It's very thin cut, but only people who can get IV contrast can get the scan. So if they're in renal failure or renal insufficiency, not quite into dialysis, you probably will not be able to get the scan. The MRI is not great. Most of us do not use this, but now there's a 4D MRI that actually is better. So it's possible you might sit for that. It just takes a lot longer to sit through that scan. A very new scan is the PET choline scan. The PET choline scan is very sensitive, and it's probably as sensitive as the CAT scan. It's not widespread yet. It's hard to find. I think the Mayo Clinic has it, and some other places are doing clinical trials on it. A little more difficult to find, but has been useful, especially in reoperative candidates, to find a gland that maybe your other imaging modalities can't. And then selective venous sampling also. We very sparingly do this because the CAT scan really was so much better than the selective venous sampling, especially in reoperative candidates, that we almost all stopped using this. But we still have it at our disposal because if we really can't find something, it might give us a sense to what part of the body this might be in. Is it in the chest or is it in the neck? So just a couple more slides about the exploration. There's 2 types of explorations in surgery. One is bilateral and one is a focused exploration. The bilateral neck exploration just means I'm looking for all of them. I'm trying to find all your glands. Which ones look abnormal? Those are the ones I'm going to remove. Do you have 4 abnormal glands? Are we going to remove 3 or 3.5? Are we just going to remove 1? This is the traditional approach that people have been doing for 50 years. We did change the type of approach based on the intraoperative parathyroid hormone, and I'll talk about that in the next slide. But this approach is still useful. Many people do it even as their initial approach, and that's fine. It does scar both sides of the neck, so it's important to remember that, especially if you have thyroid nodules and you might require a thyroid surgery in the future. But still, this can be done through a minimal incision. Sometimes people will do frozen sections, but usually you try not to biopsy too many of the glands because that could devascularize the glands. Usually, in my practice, I'm usually initially doing this in people who have negative imaging or discordant imaging. One image says one side, the other says another side, or if you have familial disease, which is much more likely to be multi-gland. And then the focused neck exploration is really for people who have imaging studies pointing to one side and specifically one gland. In those patients, you can go in, it's a lot faster of a surgery, you remove the gland, but you must have intraoperative parathyroid hormone. That is a necessary adjunct to a focused neck exploration. And only if your hormone levels that we check in the operating room drop in an appropriate way, and most of us know how to interpret that who use it, only then can we have claim success. It does have a 3% inherent failure rate, but so does a bilateral neck exploration. So we've kind of accepted that as our a failure rate that is just going to happen. People might recur. But if you've minimally scarred the neck, it's a lot easier to go back into the neck than if you've scarred it on both sides. So I'm going to go now for questions. I'm going to, let's see, do this now. Hopefully you can see me better. And now I'm going to go to the Facebook page and see about any questions that are posted. Okay, so I don't see any posted questions yet, but I'm going to go over some of the questions that were posted ahead of time for this event. The first one is by Angela Scherertz. Would love to learn more details about the use of PET choline, basically CT, for imaging and localization of parathyroid glands. So I mentioned a little bit about this in my talk just now, but I will show you sort of what it looks like. I have a slide, one sec, what the PET choline looks like. Let me bring it up. It looks a little bit like a SPECT CT. So if you see, it's almost like a PET CT. I don't know if you guys know what a PET CT is, but basically, let me do that. A PET CT is a nuclear medicine scan where you have a nuclear medicine image. It's kind of like the sestamibi, but it's a different isotope. It's the PET choline isotope. It's the choline isotope that then fuses with a CAT scan. And so you can see things light up. It's a functional scan, just like the sestamibi scan. Those are the only functional scans that we know of for parathyroid disease. The rest of the scans, like the CT scans, are really mostly anatomic. So if you have a piece of anatomy that we can see, this, for example, this thing that the arrow is pointing at, if we didn't have the PET part of it, it would just light up as a mass. But with the 4D CT, we have arterial and venous phases, so we can kind of differentiate those masses from lymph nodes, for example. And also we know where the thyroid is, and then we compare how dense it is compared to the thyroid. So it has certain characteristics that we can say, oh, that's a parathyroid. So it helps with localization of parathyroid. Sometimes you can have false positives, though, on the CT scans. And the same holds true for all of the scans. But this is a really nice one that has just come out and hopefully will be helpful in the future or be more available for everybody. Okay. So the next question by Katie was, why would calcitriol levels be low and PTH also low? What additional tests need to be run? So I'm not sure if you mean calcitriol itself, that's 125 vitamin D, or if you mean vitamin D 25 hydroxy. They're two separate things. And actually, I have another slide for you. Sorry. One second. Oh, I don't know how I just flipped my image. Hold on. Hopefully I still look the same. I don't know what just happened, but okay. So here's another image for you. And I'll move this here. Okay, so this is sort of how vitamin D and PTH interact. As your calcium is low, it will stimulate your parathyroid hormone, and then that will start to trigger certain things that happen in the vitamin D pathway. And vitamin D is really important for absorption of calcium, especially in the intestines and in the bones. So 25 hydroxy vitamin D, that's the one that we typically check in most people. 25 hydroxy vitamin D is the one that they want, that is associated now with many diseases, and they want you to have it in the normal range. You take vitamin D3 or D2 to sort of help increase that. That typically is low in primary hyperparathyroidism because, as you see, the parathyroid hormone helps with the conversion of that to the 125 hydroxy. So what you'll, or 125 hydroxy vitamin D, which is calcitriol. So what you'll typically get is a low 25 hydroxy for primary hyperparathyroidism and a high calcitriol level, 125 vitamin D. 125 hydroxy vitamin D. So if, with your question, I think you mean the calcitriol levels are typically not. Well, if your 125 hydroxy is low, it might mean that your parathyroid hormone is low because the conversion is not happening as quickly. I'm not sure if that's what you were talking about, but that is sort of where you see the relationships and the axis between the vitamin D and the parathyroid. Okay, hold on. Let me see if I can enlarge myself again. So funny, I've flipped images. I don't even know how I do that. Okay, so the next one was, I have two, I think, on recurrent primary hyperparathyroidism. First one by Mary says, I feel like I'm giving you not much info, but 6 years ago I had a parathyroid tumor removed. How do I test for new problems? How do I test for recurrence, basically, because I'm very tired now. Should I test my thyroid? And then another person, Dawn, was on an opinion. Oh, sorry, no, she's not about reoperative. There was someone else. She might be the only one. Okay, so recurrent primary hyperparathyroidism. Oh no, Dawn. Yeah, she did have another one. She asked about reoperation for hyperplasia. And originally, she had a surgery in 2018. She had 3 glands removed, it sounded like. She has persistent normal calciumic hyperpara with an elevated hormone and a normal calcium. Her endocrinologist is concerned about becoming hypoparathyroid with another surgery. But she still has kidney stones and osteoporosis, but she does have low vitamin D. Okay, so recurrent primary hyperparathyroidism. This is a, hold on 1 second, I'm just trying to get to, okay, recurrent primary hyperparathyroidism does happen. If you're with an experienced surgeon, it's only in about 3% of people. But it can be up to 20% of people depending on what your first surgery was and depending on what your pathology is. To test for it, it's the same way that we test for your original disease or a diagnosis. It's usually your calcium level, your parathyroid hormone level, your vitamin D level. Sometimes we check an ionized calcium, which can be elevated when your total calcium is normal. And sometimes we check 24-hour urine levels. But we basically would diagnose it. And then you have to decide, is it a recurrence, a true recurrence, or is it maybe due to other things? So Dawn, for example, I don't know your case, but I do know that an elevated hormone level can happen many times in patients who undergo parathyroid surgery. Sometimes it's bone remodeling, but that usually will kind of even itself out after the course of 6 to 12 months. But many times it's due to low vitamin D. So if the longer you have persistent low vitamin D, the longer your hormone level will stay in that mildly elevated range. And it's very difficult when you're talking about reoperative surgery if you only have one parathyroid left. Your endocrinologist is right. If there were 3 truly hyperplastic glands removed and you have one left, you do risk hypoparathyroidism if you treat it. And so sometimes endocrinologists in that situation will use Sensipar to try and keep the calcium levels down. There's other medications to try and prevent the kidney stones. There's also some medications to prevent or try to treat the osteoporosis. It's a difficult situation. Hypoparathyroidism is a very hard thing to live with. Going in and trying to take part of one gland is hard as a surgeon. You can devascularize the gland very easily. And unless you reimplant it, which in itself 20% of the time doesn't work, it's important to have that discussion with the patient. In addition, there are higher risks for reoperative candidates. So many of you know that on your initial exploration, there's a risk to your recurrent laryngeal nerve, which is the nerve that moves your vocal cords and helps you speak. Basically, it moves your cords. So if your cords are, if let's say it went fine, your cords are working, your nerve is fine. Usually the risk is about 5% temporary, 1% permanent that will happen in inexperienced hands. In the reoperative setting, it's triple that. So it's 15% temporary and 3% permanent. So you really have to make sure that usually we'll have multiple imaging modalities that will point to a target, and that's where we'll go. We won't, mess around in there, explore like we could the first time in a reoperative state, because It's much more scarred and it's much higher risk. In terms of Mary and talking about her tumor being removed and now she's tired, yeah, you can get your labs redone and see if you have recurrent disease, and you might be benefit from another surgery. Of course, yes, thyroid, hypothyroidism can cause similar symptoms. Many things can cause similar symptoms, but definitely reach out to your endocrinologist and see if they want to retest you. The next question is from Sarah. I guess it's not really a question. It's just a statement about being diagnosed with hyperparathyroidism. I have some symptoms for many years. Others, more severe ones, seem to be getting pretty severe over the last 2 months. I get periods where I become extremely weak and feeling as if I'm vibrating. This usually happens out of nowhere. Can literally feel great, and in half an hour I have to get in bed. Severe fatigue is a problem with primary hyperparathyroidism. Vibration, not so much usually, but fatigue can be an issue. Sometimes, though, if the fatigue is so bad, I warn a little bit that if you had parathyroidectomy, it may not cure it completely. That's the same as like severe depression, for example. People can have some mood disturbances with primary hyperparathyroidism, but if you have a major depressive disorder, it's probably not going to be cured. But I will say that having this disorder probably accentuates anything that's causing an underlying problem. So it's not bad to get it treated because at least you can cross that out the list. And after a few months, if your symptoms persist, then you can kind of look into other etiologies. The last question I have here is from Michelle. And she says, hi, I'm curious about a high PTH, 135, with a regular calcium. If a surgery was done in 2018 and one adenoma was removed, why is the hormone high again? PTH and calcium have been checked every 6 months, and the PTH has been slowly increased over time. The endocrinologist says no worries, but I want to know why there's a range for PTH levels if it doesn't matter that they're high. It does matter that they're high. I don't know if you started with a high calcium originally, but there is persistent or recurrent disease. As we were talking about, parathyroid hormone can be elevated due to other factors that are not recurrence, but certainly recurrences can show up this way. So depending on how difficult the first surgery was, how many were removed the first surgery, you might benefit from a second surgery if they determine this is a recurrence. PTH levels that are elevated to 135, yeah, they can be recurrent. We do have normal ranges. You should, though, for sure look at the normal range for your lab. So if you're a lab, I don't know if people know this, but a normal calcium range in one lab is not the same as the next lab. It can be down the street different. The labs come up with their normal ranges based on the population that they treat, or that they're testing. So if there's a large population, they'll figure out what is the normal calcium level. Sometimes high normal is 10.2. Sometimes high normal is 10.7. And so what we do as endocrine surgeons and most endocrinologists will look at the normal range and see if you're actually high to that normal. So the same is with parathyroid hormone. Sometimes hormone ranges, I've seen PTH normal as high as 88, but 135 is usually abnormal. So it's not unreasonable to investigate and make sure that you don't have a persistence. Sometimes, like I said, they can be due to other factors like low vitamin D. Sometimes people with BFHH can present this way. So, talk to your endocrinologist, and if you need to, get a second opinion or come see one of the endocrine surgeons. So okay, let's see. I think some more things have come up on the left. Okay, Lala asks me, my parathyroid is inside my thyroid. Is that complex? So that is one of what we call ectopic parathyroid glands. It's interesting. It's called intrathyroidal parathyroid. And in the beginning of this talk, I talked about embryologically they could happen everywhere, and that a couple of the glands can develop with the thyroid. This is usually what happens when they develop with the thyroid. All of them develop with the thyroid, but sometimes they can develop inside the thyroid. This intrathyroidal parathyroid can sometimes just be a very large parathyroid that is partially intrathyroidal. And those of us like myself who do our own ultrasounds of the neck can see this. I can usually predict it, and I speak to my patients and say, This is half inside your thyroid. And typically I can carve it out, but many people who don't know that that's the case and they go in without knowledge of what the ultrasound looked like can miss it. Because sometimes the thyroid capsule is actually covering that parathyroid gland. And the parathyroid gland can be big like this, but they won't see it because it's covered by a thyroid capsule. So it's not unusual. I have seen it many times, but usually we can take it out or carve it out, especially if you know it's there. Sometimes you do have to remove that side of the thyroid, though, to remove it safely and to not leave any parathyroid tissue within the neck. If it's truly 100% in the middle of the thyroid, then yes, you'll need that side of your thyroid removed in order to successfully treat the disease. I think I answered Dawn's question before. What is the recurrence rate of another adenoma after surgery? So again, that's an Annalisa. That's again due to the skill of your surgeon, and if they have intraoperative parathyroid hormone available. You should try to find a surgeon that's very experienced, but also that has that available. It is a very good tool that can decrease the recurrence rates because we can see the hormone levels drop in the operating room. For example, if you have 4 glands and let's say we take out 2 and the other 2 maybe look normal, maybe a little abnormal, it's hard to tell, and your hormone levels drop, but then they start to flatten out above the normal range. Then we know that we need to take 1 more out, for example, and then it will come down. Or you take 1 out and everything kind of drops the way it should. That's important to know. So that really helps. So the recurrence rate, though, is never, it's never 100% cure rate. Anybody who tells you otherwise is lying. So it should be about 97%. And then if you do recur, hopefully you go back to an experienced surgeon, that same surgeon who's been in your neck and understands the neck a little bit better. Okay, Melissa asks, a kiddo had 1 adenoma removed yesterday, and today she has tremors and tingling. She's on additional calcium. And we'll go back to the doctor next week. How long is the additional calcium needed? She was at 12.6 and now 9.9. Yes, okay. This is very common. So if you're at a very high calcium level when you're coming into the surgery, those are typically big adenomas. Sometimes they're multi-gland disease, but a lot of times they're one big giant one. And you remove it, the body is amazing. The parathyroid hormone is so sensitive, and the body is so sensitive to it that it immediately, if you saw that picture that I drew earlier, that was about the hormone levels going up and down, this is instantaneous. So when this happens, the hormone just drops acutely, and then your bones are just sucking in calcium, and you get a little bit of a bone hunger, and your entire body that's been used to a level of calcium that's 12.5 is now trying to get used to 9.9, for example. And that drop is really hard for your nerves to because they have to kind of basically reassess themselves. Receptors have to decrease, and a lot of things have to happen to the nerve itself, and to your muscles that are all used to a much higher calcium level. So when you drop like that, you need a buffer. So all my patients that drop like that, I put them on calcium because they're always going to have this problem. And it should even itself out over the next week or 2. Usually you'll slowly decrease the amount of calcium that they need. And it's all because of symptomatic. It's just your body getting used to a new normal. So that's very common, and it will go away. Let's see. Annalisa asks, will taking high doses of vitamin D make any difference? I don't know if this is reactive to, if that's related to the, should you ask something else? I feel like you did. Okay. Oh, you're talking about the recurrence rate. Okay. I don't know if this is in relation to the recurrence rate or not, but if you're taking high doses of vitamin D, that makes a difference typically if you have normal glycemic hyperparathyroidism with very low vitamin D. So usually you'll get high doses of vitamin D that will help correct the parathyroid hormone levels if your calcium levels are normal. Connie asks, any suggestions for how long parathyroid hyperplasia patients should follow up with their endo following surgery? I usually tell my patients to get their calcium levels checked once a year. I think I had a hair in my face. So I don't usually chase after this. I think people can get really obsessed with the labs and is it normal, is it not normal, is it normal, is it not normal, and it can really affect you. And a lot of things can kind of change over the course of time. But a good rule to follow is a 6-month level. After your surgery, you get your levels at 6 months. If they're good, then once a year after that. I wouldn't chase it more than that, in my opinion. Okay, Connie. Member Michael Melvin. Hello. Michael Melvin says, hello, happy you're doing this talk. We all appreciate it. What is the data and your experience for recovery after surgery? It seems like people recover really well and others see minimal results. Are there any variables such as age, sex, single adenoma, hyperplasia, length of disease that affect your recovery process? Also, are muscle spasms cramped a pre-op symptom? Okay, so yes, recovery depends on the patient and the surgeon and how long and the age and how long it took to find whatever we needed to find, were we successful, etc. So typically, and it also depends on, how big your incision is. Most of my patients, for example, have a very small incision, so they have minimal pain in the neck, but they do have a lot of throat pain because I use an intraoperative nerve monitor. This is, a lot of surgeons use this just to make sure we monitor the function of the nerve, the recurrent laryngeal nerve during the surgery. So you can get sore throat from that. You can get a sore back and a sore neck from just being hyperextended for a period of time. Sometimes this is a quick operation, very quick. Sometimes it takes a long time to find all 4 of those glands, especially the bigger your neck is, the more fat you have in your neck. If you have thyroiditis, if you have lots of lymph nodes that are enlarged because of thyroiditis, there's lots of factors that affect the way that we look for and try to find all your parathyroid glands, and especially in those people who we don't have negative imaging. So a lot of factors, and I'm just talking about immediate post-op issues like pain, pain control. In terms of your symptoms and feeling better, it's variable, and I'm not sure we can predict who will do better than others. What I typically tell people is that about 75% of people will improve with their symptoms after surgery, at least one symptom. And so we can't guarantee that all your symptoms will be alleviated because a lot of things, they overlap with this. And we also can't guarantee that many of your symptoms will be alleviated, but many people do benefit from this, even those that are normal calcemic. They do benefit. So, I've had people wake up the next day, and say, oh my God, my joint pains are gone. But then I've had people that it takes a little while for that to happen. Sometimes the anesthesia makes you so tired, and the older you are, it's harder to kind of recover from anesthesia. So that's also an issue. It's variable. But what I do tell patients is that if your symptoms have not resolved and if we're successful, we cured the problem and your symptoms haven't resolved by 3 months, I would look for alternative causes. And in terms of muscle spasms, not typically. Sometimes I guess if your calcium levels are so high, but usually muscle spasms and cramps are due to low ions, low potassium and low calcium. Sometimes it can happen after the surgery if your body's used to a higher level of calcium. Damon has asked, my parathyroid level had been high due to an overactive gland found in my thymus. I had all the symptoms, was very tired, unable to concentrate, high calcium levels. Lately, however, I noticed that many of the symptoms have gone away. My question is, can overactive parathyroid gland actually heal or reverse itself? I'm not taking any medication currently. Thank you. So I assume you have not had surgery for this overactive gland. No, the parathyroid will not regress. It won't heal itself. So you're going to always have it, but I'm glad to hear you're feeling better. Yes, they can be in the thymus gland. Sometimes they're in the high thymus, so we can take it out from the neck. Sometimes they're deep in the chest, so we have to have a thoracic surgeon remove that thymus adenoma. But depending on your age and your calcium level, all of those things and all of those factors are, how aggressive you want to be about removing this. But typically, if you're not on a medication like Sensipar, you will not, it will not regress. Let's see, Connie from Veronica. I've had all 4 parathyroids removed. What should I be doing health-wise apart from taking calcium tablets? I'm sorry to hear that you've had to have all of those removed. That's a tough situation, I know, and you're probably having a lot of symptoms and having to take a lot of calcium. So people with hypoparathyroidism after parathyroidectomy, which does happen, it sometimes even happens when you take out 3. You require calcium to take calcium. A lot of people will take calcitriol. And if you're not able to control your calcium levels with that combination, there are injectable parathyroid hormones. But those, there's one that a lot of people were on called Natpara. It was removed from the market, I think because of the injectable device. It should be coming back online soon. But it's something to talk to your endocrinologist about. It can be difficult to have to be on this lifelong, but sometimes this happens. I will tell you in the pipeline, there are some parathyroid, they're thinking about implantation of parathyroid, like transplants from donors. And they're seeing that, at least in the lab, you might not require a huge amount of immunosuppression, which is what the problem was initially. And you might actually get some benefit from it. So that might be in the pipeline for you at some point to try and get off the calcium levels. I would ask your endocrinologist about that. It's not quite live yet. Connie asked from a member Marianne, I'm 71 years old and had 3 parathyroids removed in 2017. I do take levothyroxine every morning plus 1,200 milligrams of calcium and vitamin D. I suffered from kidney stones prior to my surgery. I was diagnosed with hypothyroidism. I have osteoporosis and osteoarthritis. I now have to get Prolia shot every 6 months. My osteoarthritis, doctor has blood drawn with my Prolia. I now suffer hot flashes that I never had when I went through menopause. I have to put so much weight, I have put on so much weight, and I worry that my thyroid meds are not the correct dosage. Okay, I'm not sure if this is a question, but if you're talking about your thyroid dose, you can get those checked and see if you require some more thyroid hormone. Hopefully your calcium and parathyroid hormone levels are in the normal range. It's not atypical for people to still get Prolia shots after parathyroidectomy, although I will say that once you get a parathyroidectomy, it will help your bones. Typically, you will see a halt in the progression of your bone disease, and it'll start to regress a little bit. So I'm not sure if I answered your question, but hopefully. Lala asked, does hair that I have lost grow back after surgery? I don't know the answer to that, but I do know that thinning hair can be an effect of this. But sometimes thinning hair is from your thyroid, so I'll have to get back to you on that. Rebecca asked, I had parathyroid surgery and they found one, removed it, but they couldn't find the other 2 glands or the arteries that go to them. How can they find the other glands? This is tough. So imaging almost never shows you a normal gland. Sometimes the CAT scan is so good that it can show you a normal gland. Usually your surgeon has to just look at them and make sure and know that they're normal or abnormal. And I will tell you that most surgeons, even experienced ones, have a little trouble distinguishing fat from normal parathyroid. It's easier to distinguish an abnormal parathyroid. So they're probably in there somewhere. But if your levels normalized after surgery, it shouldn't be an issue. But if you recur, it's likely that your neck is scarred. So you do have to get the imaging modalities to try and find it because of how difficult it sounded like it was for the surgeon to find those glands. Let's see, I have a few more questions and then I'm going to have to stop. So let's see. Rebecca, I had parathyroid surgery. Oh, sorry, that was one I just did. Lala again, I am having very low calcium diet and my ionized calcium is in normal range, but PTH still high. Do I still need surgery? I can't really comment on your individual case because unfortunately I don't have all the necessary information. So I'm sorry about that, but I'm happy to consult on you if you'd like. Oh, thanks, Melissa. You wrote a big thank you to me. Raya, I have an upcoming surgery on May 29th for hyperparathyroidism. I have Hashimoto's. What are the chances the parathyroidectomy will cause issues with my thyroid? I very recently had a post-viral issue that my thyroid, and my levothyroxine needed to be decreased twice. Thank you. That is a good question. That's interesting that you had that. So you had 2 things going on. The viral thyroiditis, yes, that can cause hyperfunction of the thyroid, but you'll probably need to go back up on the thyroid dose. Hashimoto's, the only thing that it will affect is typically that the thyroid is stiff, and we have to work around it, and it inflames most of the area. So sometimes it can scar the area a little bit, and sometimes you have inflamed or enlarged lymph nodes. So if you have those things, it's a little bit harder to find the parathyroid gland, so it might take a little longer. In terms of the function, people with normal thyroid function, when we do parathyroid disease, can have something called palpation thyroiditis. So your thyroid could feel like you're hyperthyroid. Suddenly your heart's racing and you can't sleep and you don't understand what's happening. It usually means your thyroid just released a lot of hormone while we were operating, and it just goes back to normal over a few weeks. In your situation, I don't know. It could happen, but it probably is not functioning too much as it is, so you probably have less likely for that to happen for you. Susan asked, hello doctor, excellent information, thanks. I have low normal calcium and really bad osteoporosis, T-score of -4. I take vitamin D weekly and high PTH. Had surgery. Doctor could not locate parathyroid glands due to scar tissue from 2 previous thyroidectomies. He wants to wait 6 months and rescan, not taking anything for osteoporosis. He wants to hold off on that as well. Any recommendations? Okay, that's hard. You have a reoperation with a scarred neck. Nothing ever removed. I'm not sure why your calcium levels are low. It could be, and especially because you're not on any osteoporotic medications. Usually when you're osteoporotic medications can cause low calcium. But is it at all possible that your calcium is so low that it's causing an increase in your hormone level? Sometimes that can happen as well. I just don't know your individual story, so it's hard for me to give you any medical advice. I would just talk to your endocrinologist, and if you need a second opinion, you can get a second opinion. From Linda, my urine calcium is 350 and blood calcium is 10.8. I have so many symptoms, but I'm exhausted all the time. Will this go away with surgery? So fatigue, usually, a lot of times fatigue will help with, the surgery will help with your fatigue. A lot of people get a lot of energy back, unless it's due to some other cause. People have low energy for a lot of reasons. In terms of your high urinary calcium, yes, that should decrease with the surgery if it's successful. Alice asks, do you always check all 4 glands in surgery, or do you remove only the adenoma, and if the PTH drops is removed, not check the other glands? If so, why? So yeah, if you look back into the earlier part of this broadcast, I kind of talked about that. I am a surgeon that does focus exploration if you can. You have to have imaging studies that point to one gland. So if you do, then we can remove only the one, but you do have to interpret the parathyroid hormone levels really carefully. And that's what we do. I keep the patient on the operating room table, and if the hormones levels drop the way that I expect, and sometimes that's in the normal range needs to be, sometimes it's a percentage drop, sometimes there's a lot of factors that I use, then I will just take out the one gland. Otherwise, I will do a 4-gland exploration on people who have discordant imaging or negative imaging. I do not do it on everyone always. I do not like to scar the entire neck because of patients that will end up possibly needing reoperative surgery and how much more difficult it is in that situation. And then April asks, is it possible to have high parathyroid numbers, one test, and then low 6 months later? Yes. So some parathyroid hormone levels in primary hyperparathyroidism, you can go in and out of normal all the time. You can go calcium high, calcium normal, parathyroid hormone high, parathyroid hormone normal, especially those people who have high calcium with mid-normal parathyroid hormone levels. In those situations, I do rule out BFHH, benign familial hypercalcemic hypocalciuria, because those people can do that as well. But as long as your 24-hour urine level is high or normal, usually it's not BFHH. So yes, that can happen. Veronica asks, what happens to my bones absorbing calcium and vitamin D without any parathyroid hormone? You mean zero parathyroid hormone? If you have no parathyroid hormone, your bones are still going to absorb it. You need to take vitamin D orally and take calcium orally. And then sometimes the synthetic parathyroid hormone that I spoke about earlier. Okay. Lisa, why is it that postmenopausal women seem to get this, gain weight, and then have a hard time losing? Any may have also hyperplasia. Do they also have hyperplasia? I think that's what you meant to say. This is the most common in postmenopausal women, you're right. Well, really mostly from 40 to 60. That's the most common age, but some men get it, but most commonly women. But more and more we're seeing younger patients get this too. Usually it should not affect your weight. That's usually a thyroid or some other function of your body. I know many people seem to attribute it to the parathyroid, but typically it shouldn't affect the way that your weight or your metabolism is. In terms of hyperplasia, I am seeing more and more hyperplasia. I mentioned this earlier, but the majority of people are still single adenoma patients. Mark asked, I had a parathyroid adenoma removed on the left back in 2005 under my clavicle, deep in the neck, 2 surgeries the same day. Along with that, a healthy parathyroid was removed and a suspect healthy parathyroid. Okay, hold on, sorry. It's the wrong one. Okay. Along with that, a healthy parathyroid was removed and a suspect healthy parathyroid removed, both on the left, 2 healthy on the right. 15 years later, reoccurrence with calcium 12. Okay, this is a pretty long post about a specific case. So I can't, I don't know if we have time to comment on that case. Let me see if there's a few quick ones and I'll see if I can read through it. I probably will just reply to you online about this because there's a lot of specifics here, case specifics, and again, medical advice is a little bit limited for me. Thank you, Linda, for the thank you. And April says thank you. Now I understand why the 24-hour urine collection. Okay, so I think I'm going to end here. Mark, I will reply to Connie's question and any questions I haven't gotten to. But very much appreciate your time, and I hope this helped, and we'll see you next time. Bye.